Hello friends, welcome to my channel Miliha. Today we are going to discuss about obstetrics and gynecology, especially obstetrics. We are going to discuss the third topic in obstetrics and gynecology. It's going to help you in your exams in NLE, NEXT, USMLE, PLEB, and any other MBBS exam. We are discussing today about the fetal skull. It's going to be a little bit long lecture of about 20 to 30 minutes, but it's going to clear your many of your doubts. So please be attentive and take a pen and pencil or notebook or whatever you have. We are going to discuss about the third topic, which is about fetal skull, maternal pelvis, normal label, puerperium. We are also going to discuss about the presentation, what is presentation, and stages of labor, mechanism of labor, and Bishop score. We are going to discuss about all these things. Why we need these things is because we are going to decide as a doctors or as a gynecologist, obstetricians, you are going to decide whether the delivery of a child should be vaginal or by medically induced vaginal, or it should be surgical. For example, you have to do a cesarean section. That decision, to make the decision, these parameters will help you in your future practice. So let's start. It's about lie. Here, the lie. What is lie? It's a relation of longitudinal axis of fetus to the longitudinal axis of maternal pelvis. That means how the baby fetus is inside the womb of the mother, how it lies. For example, it's in oblique, or it's in vertical or transverse or whatever. That is called the lie. Next is presentation. That means which part of the fetus going to occupy the lower pole of the uterus. For example, whether it occupies the head, occupies this space, or the buttocks. In case of breech presentation, if the head occupies the lower pole of the uterus, it is called cephalic or cephalic presentation. So the part of the head is presentation in this case. So here the buttocks or the sacrum is presentation. So 96.5% is the cephalic presentation, 3% is breech presentation, and there is 0.5% shoulder presentation, and others include compound presentation, in which the head and the hand, for example, this is called compound presentation, when you feel a hand along with the head of the baby, or the fetus. So this is shoulders presentation. This is cephalic presentation. This is breech presentation. This is lie. This is transverse lie. Okay. So here I have explained you about the presentation. Presenting point. What is presenting point is again a small part of the presentation is called presenting point. So it is a part of presentation which overlies the internal os, okay, which is presented to the, that is called presenting part. In fully flexed and slightly deflexed head, presenting part is vertex. What is vertex? Is this part is called vertex. Okay. In extended head, the presentation part is brow. So this is brow. Okay. In extended head, extended means when your head is like this. Flexion means your head is like this. Okay. In fully extended head, the presenting part is face. If the fetus head is fully extended, here we have some images, figures, you can check them. This is vertex. Presenting part is vertex because the head is flexed. The head of the fetus is in this position. So this is little bit up, little bit deflect. So this is sinciput. This is brow presentation. In this diameter is mento vertical diameter. What is mento is your chin. From chin to the vertex is called mento-vertical diameter of the skull. This is occipitofrontal diameter. From here to front, this is occipitofrontal. Okay, vertex presentation, the diameter is suboccipitobrachmatic. Brachma is here, a star shape. Okay, that is suboccipitobrachmatic diameter. Next is face presentation. In face presentation, the neck of the fetus is fully extended, so the presenting part is face. So face. In all of these are cephalic presentations, and presenting part is vertex, since put brow and face. So in this position, the diameter is very large, so vaginal delivery is not possible. So low segment cesarean section is done. Attitude is the relation of different parts of the fetus to each other. For example, the fetus is in uh, flex position, so flexion. So all his limbs are in flex position, including his neck and head, his arms and his legs, everything. That's the universal attitude. Okay. Denominator is again a small part of the presenting part. Okay. The presentation means head, the presenting part means vertex, and again a small part is called denominator, again a small part. So vertex is in vertex presenting, if the presenting part is vertex, in that case occiput is the denominator. If the presenting part is face, face is going to the internal to fit the internal os of the cervix. In that case, the denominator is mentum. Mentum means your chin. Brow presentation, frontal eminence is the presenting part. In breech presentation, sacrum is the denominator. In shoulder, okay, here we will write shoulder presentation, acromion is the presenting part. Position, it is the relation of denominator to the different compartments of the pelvis. For example, if it is occiput, then it should be anterior or posterior or lateral or left or right. That is called position of the fetus. So here there are 8 positions of the fetus. I am going to explain you everything with some images and figures so that you can understand the concept, and it will help you a lot in your exams. Believe me, listen to me carefully, okay? There are 8 positions of fetus, 3 anterior, 3 posterior, and 2 transverse positions. So let's check them in the diagrams here. So this is occiput, okay? This is front. So this is tilted towards right. This is the right of the patient is your left. So this is right of the patient, this is left of the patient. This is symphysis pubis, the bone. Okay, this is sacrum. So here the fetal head, this is fetal head. So it is, the occiput is tilted or directed towards right. So it is called right occipito anterior. That is the position of the fetal presenting part, okay, or fetal presentation. Here it is when the occiput is directed toward the symphysis pubis. That's anterior, it's called direct and occipito anterior, DA is 2%. This is 10%, this is 2% left occipito anterior. This is left because the occiput is directed towards the left. So left occipito anterior 13%. So right occipito posterior, similarly the occiput is occipital is towards back or towards the sacrum. So that's right occipito posterior, direct occipito posterior, right occipito anterior 3%, and this is right occipito transverse, the when the head the presenting part is uh, uh, in transverse position. This is called, this is occiput. In this case occiput is directed towards right, so this is right ROT, a right occipital transverse, is 24%, and left occipital transverse, this is 40%. So this was about the position of the fetal head presentation. Okay. Diameters of fetal skull. Largest diameter of fetal skull is mento-vertical, 14 centimeter. Presentation of head in partially extended head is presentation is bro. Okay. So uh, presenting part is uh, presenting part is bro. In this case, there should be presenting part is bro. In bro presentation, vaginal delivery is not possible, as I had mentioned earlier. It is going to decide because the diameter is very large. It's 14 centimeter. So the vaginal delivery is not possible. So you have to do an LSCS. That means low segment cesarean section. Okay, is done. Management of persistent mento-posterior position is also LSCS. Smallest transverse diameter of the fetal skull is bimastoid. It is 7.5 centimeter. Bimastoid. Okay. Bitemporal diameter is 8 centimeter. Best parameter to assess gestational age during the first trimester is crown to rump length, CRL. This we had studied in the previous chapter 2. So here again it's a revision. CRL at 7 weeks is 10 millimeter. Okay. Best fetal parameters to assess gestational age at second trimester is biparietal diameter. Biparietal diameter at 34 weeks is 9.4 centimeter. Biparietal diameter BPD at term is 9.8 centimeter. BPD at post-term pregnancy is 10.1 centimeter. So if you see a fetus with the biparietal diameter 10.1 centimeter, you should diagnose it as a post-term pregnancy. So here you can take a screenshot, and you can also take the screenshot of the above. I had shown screenshot of this, and again this one. You can pause and then take screenshot, and this too. So let's proceed further. We had studied this. So here we are going to study about diameters of the fetal skull in vertex presentation. Vertex means this part is uh, the vertex, so is suboccipitobrachmatic. Brachma is here, suboccipit is here. Here is brachma. Okay, suboccipitobrachmatic, 9.5 centimeter. These things you should learn. These things you should write and learn. Okay, so you should remember them. Diameter in face presentation, you should not be worried. As much as you can, you should remember. If you cannot, you should leave them. You should not be worried about them. Okay, let's proceed further. Diameter in face presentation is submentobrachmatic. It is 9.5. Normal vaginal delivery is possible. Okay, in face presentation, normal vaginal delivery is possible, but in bro presentation, normal vaginal delivery is not possible. You should keep in mind these two things. Okay, so here is another figure. Diameter of the, you should take a screenshot. Diameter of the fetal skull, diameters of the, so this is mento-vertical, the largest diameter from the chin to here. Mento-vertical is called, it is 14 centimeter. It's called bro presentation. Then suboccipitofrontal is 10 centimeter. Submentobrachmatic, this is mento, this is submento. Okay, submento is here, and mento is here on the chin. Okay, submentobrachmatic, it's 9.5 centimeter. This diameter I have already told you. This is suboccipitobrachmatic. This is suboccipito. This is occipito. This is vertex. Okay, suboccipitobrachmatic. Suboccipitobrachmatic. This one is 9.5 centimeter. So occipitofrontal. This is occipitofrontal. Okay, this is deflex vertex. This is called deflex vertex. Okay, let's proceed. What is caput succedaneum? Caput succedaneum is when there is a swelling, okay, under the skin, swelling over the scalp, seen at birth, diffuse cross suture line. Treatment is not required. Caput succedaneum is a swelling over the scalp due to the birth. Okay, it resolves in few hours after birth. You don't have to treat it. Okay, pitting is seen. Pitting, if you press, there becomes a pit in this case. Okay, cephal hematoma or cephal hematoma, blood clot seen below the periosteum. Periosteum is the covering of the bone. So that is uh, more dangerous, uh, or you can say severe, than the caput succedaneum. Caput succedaneum resolves within few hours, but it takes about 6 to 12 weeks. That means 1.5 month to 3 months to resolve. It causes prolongation of the physiological jaundice. There is a physiological jaundice. That means when a child is born, he will undergo a physiological jaundice. That is not a disease. That is not pathological. That is physiological. In this case, in uh, cephal hematoma, prolongs the physiological jaundice. Okay. Here you should take screenshot of these notes. Okay. Pelvic diameters, anatomical conjugate, true conjugate of inlet of maternal pelvis is uh, 11 centimeter. What is conjugate? You can call it a diameter too. It's also a kind of diameter. Okay. So anatomical conjugate, true conjugate, both are the same. Maternal pelvis is 11 centimeter. Diagonal conjugate is 12 centimeter. It is the largest conjugate. It is the only conjugate which is clinically measured. You can clinically measure this conjugate. Okay, obstetric conjugate is smallest conjugate, 10 centimeter. Okay, I will show you these conjugates in a picture, in a figure. Okay, smallest transverse diameter of the maternal pelvis, bispinous diameter. Okay, bispinous. There are ischial spines in the pelvis. Between the spines, the diameter, if you measure, it is the smallest one. Okay, diameter 10.5 centimeters. So here conjugates are diameters of the female pelvis. Here, this is symphysis pubis. This is sacrum, promontory of sacrum, you can say. So this one is anatomical conjugate or true conjugate. The red one, the green one is obstetric conjugate, and the lower, the blue one is diagonal conjugate, and this one is anterior-posterior diameter of mid pelvis. Okay, so you can take a screenshot and remember it. Stations of delivery, ischial spine is at zero station. Okay, zero. What is station? Is when the head of the fetus is descending. During this, it comes down centimeter by centimeter. So we have to measure from the ischial spine, and we take the ischial spine as 0 point from above. We take it -1, -2, -3, -4, and from the 0 point below, +1, +2, +3, +4. These are the stations of the head of the fetus. Okay, they can indicate, predict the prognosis of the delivery, the birth, that how it will undergo, whether it is possible or impossible, or it's difficult or easy. So I will show you again with the help of, so ischial spine is at zero station. Deep transverse arrest occurs at bispinous diameter. Deep transverse arrest occurs at bispinous diameter, because this is a small diameter, so here the head stuck, so it's called deep transverse arrest. So internal rotation of the head occurs at ischial spine during second stage of labor. Okay, so in during second stage of labor, uh, then when the child is actually born, so at that point, uh, internal rotation, thereby there is a mechanism of labor. So step by step, they are also called cardinal movements of the fetus that I will explain you later on. Okay, internal rotation of head occurs at ischial spine during second stage of labor. Best method to do pelvic assessment is radiopulvimetry. Okay, best method to do pelvic assessment is radiopulvimetry. Trial of labor is given at inlet contraction mild. Okay, now here is these are called the stations of the fetal head stations during delivery. This is ischial spine. You can say this diagram I have made with my hands by myself. So excuse me if it's somehow not an artistic, but you can take an idea. Okay, so this is the red line is at zero station. Okay, above it is plus 1 plus 2 plus 3 plus 4 in centimeters. Below plus above is minus, sorry, above is minus. When the head is here, it has not descended, the head is here, it's called the head is at plus 4 station. If the head has already almost delivered, it is called plus, it's called, above one is called minus 4 and below one is called plus 4. So middle is 0. Okay, so this is ischial spine. These are bimanual fingers to examine. Okay, let's go further, proceed. There are four stages of labor: pre-labor, Brixton, hiccups. Okay, the Brixton hiccups are pre-labor. Okay, the woman or the female, the pregnant female can experience some hiccups or some kind of contractions. They are called Brixton's hiccups. After that, in the first stage, you can say, okay, in this stage, there is effacement and dilation of cervix. What is effacement? I will explain you. It's actually thinning of the cervix. Okay, the cervix become thinner, and dilation means the cervix opens. So it takes about, this stage has two phases, latent phase and active phase. It takes about 14 to uh, 20 hours depending on primigravida or multigravida. That means whether the female, the woman is bearing a child for the first time, or has already bore a child. So we will already born a child, we can say in that way. Okay, or she has already delivered a child, that is called multigravida. Anyway, so in the second stage, delivery of the baby 1 to 2 hours. This in the second stage, actually the mechanism of birth take place, the mechanism of delivery, the mechanism of labor, actually it is called labor. So the mechanism of labor actually takes place in the second stage. So it takes 1 to 2 hours. Okay, after the second stage, when the baby is delivered, then the placenta is delivered. So it takes, that's called the third stage of delivery. In this third stage, it, it takes about 15 minutes to 1 hour. Okay, earliest sign of placental separation, change in consistency and shape of the uterus. If the placenta separates from the uterus inside, okay, then there is change in consistency. Okay, it's inconsistent. So defined signs of placental separation is detached placenta felt in the lower segment of uterus. So definite sign, what is the definite sign of the placental separation? When the placenta is separated from the uterus, it's a dangerous situation. Okay, so how we will diagnose it and understand it? This by we can feel the placenta in the lower segment of the uterus by our hands. That is definite sign of the placental separation. Okay, effacement. Now I had told you the effacement is thinning of the cervix. So what is cervix? This is cervix. Okay, this part, this is uterus, this is the head, or you can see, you should suppose it as a head of the fetus, of the child, of the baby. So this is fetus. So This is part is the more red or pinkish part is uh, the uterus, and this part, the orange part, is cervix. So this is vagina. So here it is 0% effaced because you can see the length of cervix is larger and it's thick. Okay, here it has become little bit thinner than this, about 50% effaced. Here it is has become completely effaced and it has become equal to the walls of the uterus. So it's 100% effaced, but this is not dilated. It's effaced, 100% effaced, but it is not dilated. Okay, this is also not dilated. This is also not dilated. Here it is dilated. This is called dilated and effaced. So now you understand what is effacement. Let's take a screenshot and proceed further to the next. So this is the sequence of the mechanism of childbirth. What happens is the um, head of the fetus or whatever the presentation is comes and engages with the diameters of the pelvis. The diameters of the head engage with the diameter of the pelvis. So that's called engagement. After engagement, it descends. The head starts to descend slowly. That is called descent. After descent, after a little bit descent, it flexes. The head flexes. This is extension. This is extension, but this is flexion. The head flexes. Okay, after flexion, it goes internal rotation to negotiate with the anatomy of the inlet and the room of the pelvis. To negotiate with the anatomy, it rotates internally so it can pass out. Okay, so in this time, the head, the face might uh, um, twist or might turn towards the back or towards the sacrum. It rotates and turns towards the sacrum. So that's called internal rotation. After that, it comes out under the symphysis pubis and it's visible, little bit visible from the outside through the cervix. So that is called crowning because the um, head is crowned by the external os of the cervix, okay, or the vagina. So after crowning its extension, now the head underwent, first it underwent flexion, now it undergoes extension. Okay, and with the extension the head is born outside from the vagina. Okay, as soon as the head is born and it emerges outside, it comes back to its natural anatomical position. It's called restitution. Restitution because it had undergone a twist inside. Now it again twist backs, turns back. So that position, that is phenomenon is called restitution. After restitution, the shoulder also undergoes a rotation. That due to the rotation of the shoulder inside, the externally the head rotates furthermore. So that is called external rotation of the head. After the external rotation, lateral flexion takes place. Lateral flexion, with lateral flexion, the baby is born completely. That's also called expulsion. Lateral means the baby twists like this and he is born outside from the vagina. So here are the steps, the mechanism of labor. This is the mechanism of labor. Okay, just I had explained you. So this is engagement, means the head comes and engages with the pelvic inlet. This is descent. Now it has come down. Okay, now it has undergone flexion and the baby looks down, is flexion. Okay, after flexion, this is the fourth step, internal rotation. You can see the face of the baby is down towards the sacrum. Then extension. With extension, the head is born. This is extension. And this after head, then restitution and external rotation. The head here, the head looks down, but here it looks up, so it has turned back. So it's restitution and external rotation. After external rotation, here is the expulsion with lateral flexion, lateral upwards. Okay, flexion completely. The baby is born completely. Okay, after that, we are going to check some more things. Latent phase is up to 3 centimeter cervical dilation. True labor pain is because of oxytocin. Oxytocin is a hormone secreted by posterior pituitary gland, which induces the uh, initiates or instigates or induces the labor naturally. Okay, fast labor pain occurs due to irritation of neighboring ganglia. There's fast labor pain. Why? What is the cause? Etiology? Neighboring ganglia irritating. Okay, treatment is sedation and enema. Okay, if the pain, due to pain, you can do an enema, which makes the abdomen little bit lighter in weight and helps in child labor, sorry, in labor or in delivery of the baby. Okay, sedation also, you can sedate somehow to uh, relieve the pain of the patient. Okay, puerperium is the period of about 6 weeks after the childbirth, during which the mother reproductive organs return to their original non-pregnant condition. Within 6 weeks, 1.5 months, the reproductive organs of the mother come back to their original non-pregnant condition. Okay, that you will remember. Within 1.5 month, it's too soon, I think, but it's true. So that period is called puerperium. Okay, duration of lochia. What is lochia? Is a liquid is secreted after the childbirth for about 3 weeks or 1 month. The secretion occurs continuously. That secretion is called lochia or lochia. It's better you call it lochia. So duration of the lochia is 3 weeks. Uterus becomes pelvic organ in 2 weeks after delivery. Okay, um, just after delivery, within 2 weeks, the uterus comes back to the pelvic organ. Okay, before that, when the woman was pregnant, the uterus may become large and can go to till the abdomen, but after within 2 weeks it descends back to the become a pelvic organ. Okay, there are three types of lochias. Okay, lochia rubra. Rubra means red. That contains red blood cells, RBCs. Okay, 3 to 4 days. Till 3 to 4 days after delivery of the child, the woman will secrete a red uh, fluid, a liquid through her vagina. Okay, that's called lochia. After that, lochia serosa is pinkish. It takes 4 to 8 days to subside. After lochia serosa, there is lochia alba. Alba means white. It takes 10 to 28 days to stop. Anaerobic streptococci commonly cause puerperal sepsis. Okay, this point you should remember. Anaerobic streptococcus or streptococci commonly cause puerperal sepsis. That is the infection during the puerperium after the childbirth. There might be infection to the woman. That is due to the anaerobic streptococcal. Okay, that's commonly. Uh, After that, drug of choice for suppression of lactation is bromocriptine. So if you want to artificially suppress the lactation, that you should stop the milk of the woman. Okay, so in that case, you will provide a drug named bromocriptine. Why should you suppress the milk or the lactation? Is because maybe the woman may have an abscess or mastitis, which is inflammation of the mammary glands. Although feeding and lactation is recommended, but it depends on the decision. If they want to stop lactation, they will give bromocriptine. Okay, They will prescribe bromocriptine. Partogram is the progression of labor chart used to diagnose obstructed labor. Okay, we will discuss in another video about partogram. You should just know the definition that partogram is a progression of labor chart used to diagnose obstructed labor. Okay, sometimes the labor is obstructed and it cannot be proceeded further. The delivery is impossible. That is called obstructed delivery. So that we will diagnose or predict with the help of partogram. Okay, non-progressive obstructive labor. Bishop score. This is very important. You should understand Bishop score to make a decision and to predict an induction of the vaginal delivery or spontaneous delivery, or you should go for a surgery or a surgical delivery or a cesarean delivery. So you should understand the Bishop score. So consistency of the cervix is and stations of presenting part. Actually, stations I have just explained you with the help of a diagram above. So it's about modified Bishop's score. What is modified? Modified Bishop score is also includes length in place of effacement. The modified Bishop score include includes length of the cervix. Okay, here we will discuss one by one. It has a score about maximum 13. 6 to 13 is a favorable. Above 8 can be, you can predict for spontaneous delivery. 6 About 6 to 7 you can induce with the help of mm, medical prescription, for example, prostaglandins or oxytocin. But below 5, it is somehow difficult to deliver through vagina, and it's a little bit, I can only use the word, it will be difficult if the score is less than 5. Okay, either you should go for a cesarean section, there's a surgery. Okay, so here score is 0, 1, 2, 3. Okay, consistency. If the cervix consistency of cervix is firm, you will give a score 0. If consistency is medium, a 1. If it is soft, you will give 2. Okay, position posterior. What is the position? Is I will explain you here. This, for example, cervix. If the cervix is posterior, it is posterior. Okay, it's middle is called middle. If it is directed anterior, its orientation is to the front. This is called anterior. Okay, position of cervix in Bishop score. So that's the position of cervix. Posterior, so anterior you will give a score of 2. Okay, effacement I just had explained you, it's thinning of the cervix. So how thin it has become, according to that, if it is 30%, you will give 0. If 40 or 51, more than 80%, you will give score of 2. If the length of the cervix is, if it should decrease, the length, if it is less, it's good. If it is more, it's bad for delivery of the child. Okay, so if the length is more than 4 centimeters, 0. If it is 1 to 2 centimeter, 2. Okay, okay. If after that dilation of cervix I just had explained to you, if it is closed, 0. If it is 5 centimeter, 3 to 4 centimeter, 2, 5 centimeter, 3, score of 3. Station I had just explained you, if minus 3, 0. If minus 1 to 0, 2. If plus 1, plus 2, then you will give a score of 3. Okay, on that basis you will decide. So here are some questions. This is molding is the formation of caput. Okay, the process in which the parietal bones tend to, we will discuss a little bit multiple choice questions and answers very fast in very short time within 2 minutes. Okay, molding is the process in which parietal bones tend to overlap the adjacent bones. Okay, the parietal bones of the skull of the fetus tend to overlap each other. From here they get up and overlap each other, so they can easily pass through the pelvis. of maternal pelvis. Okay, that is called molding. Now, next question, the broadest uh, fetal head diameter is, I had just explained you, mento-vertical. From here to here, it's called mento-vertical diameter is the largest. In mento-vertical diameter, the vaginal delivery is not possible. So smallest diameter of the fetal skull is, here it is bitemporal. If there would have been bimastoid, we would have mentioned it, but here is no bimastoid, it is absent, so we will choose the bitemporal. Okay, next question is, you can take screenshots of these questions and practice for yourself later on. In face presentation, diameter of the engagement is submentobrachmatic. In face presentation, diameter of engagement is submentobrachmatic. Okay, uh, submento, this is submentobrachmatic, here is the brachma, submentobrachmatic in face presentation. Okay, you should remember this. Engaging diameters in fully extended head is, it should be submentobrachmatic. Okay, fully extended submento, but uh, they have answered in a book suboccipito vertical. So I have put a question mark. Please check it again and double check it and find out the answer for yourself. Okay, here in vertex presentation, the diameter of engagement is suboccipito pragmatic. This is in vertex presentation, suboccipito pragmatic here. From here to here, this diameter. Okay, most important diameters of the pelvic inlet is diagonal conjugate. This is the most important, is the diagonal conjugate. Okay, the frequency of cephalic presentation. What is cephalic presentation is when the head delivers first. Okay, the head is down and it occupies the lower pole of the uterus and the head is down. That's called cephalic presentation. That's the common presentation. So it's 95.5% and face 0. Vertex is this vertex, this part in cephalic presentation. Vertex is 95.5%. Okay, I had already explained you the part which occupies the lower pole of the uterus is called presentation. Then a part of presentation is called presenting part. A part of presenting part is called, what it is called, denominator. A part of presenting part is called denominator. So for example, the cephalic is the presentation, that means head is going to deliver first, head is the presentation. So vertex is the presenting part of the head. Then again part of the vertex is occiput. Okay, so occiput is denominator. So here is vertex 95.5%. Okay, face 0.4%, brow 1%. In brow presentation, it's extremely difficult and almost impossible to deliver through vagina. Okay, frequency of phallic presentations. Next question, denominator in vertex presentation. I had just explained you the smallest unit is called denominator, occiput. Vertex presentation, it's occiput. Okay. In primigravida, engagement of head of fetal takes place at 36 weeks. Okay, that was the last question. Thank you for your attention, and please revise and study and get ready for our next video. And please subscribe my channel Miliha, and take care and bye bye.